Hello, my name is Yuriy Bronshteyn. I'm an intensivist and anesthesiologist at Duke, and I will be presenting the April 2025 POCUS Case of the Month for open anesthesia. This case builds on the March POCUS Case of the Month, Intro to Lung Ultrasound. If you have not already watched that video, I encourage you to do so before viewing this case. The patient is a 70-year-old male undergoing an open lower extremity revascularization. His past medical history is notable for active smoking and peripheral arterial disease. Midway through the operation, the patient develops acute severe hypoxemia, requiring FiO2 to be increased to 1 and manual bag ventilation to maintain O2 sat greater than 90%. On auscultation, his breath sounds are diminished but present bilaterally. Due to the severity of the patient's hypoxemia, a supine chest X-ray was obtained in the OR as shown on the right. Radiology was contacted for an emergent read, and they reported that the endotracheal tube was well positioned in the trachea, that there was no evidence of pneumothorax, and that the patient appeared to have mild bilateral pulmonary edema. Given the relatively unremarkable chest X-ray, pulmonary embolism remained high on the differential, so an emergent transesophageal echocardiogram was obtained and was grossly normal, including normal LV systolic function and normal RV size and systolic function. The normal RV size and function strongly argued against pulmonary embolism as the cause of the patient's severe hypoxemia. To further narrow the differential diagnosis of hypoxemia, focused lung ultrasound was then performed. To organize our discussion of the patient's lung ultrasound exam, we will use a mnemonic that some authors have proposed to help integrate diagnostic POCUS into routine clinical practice. The mnemonic is IAIM and stands for indication, image acquisition, interpretation, and medical decision making. Indication: the lung ultrasound exam was performed to narrow the differential diagnosis of the patient's acute severe hypoxemia. Image acquisition: due to the presence of surgical drapes covering most of the patient's body, lung ultrasound was focused on anterior lung zones. Specifically, a sector array ultrasound transducer was placed near the mid-clavicular line, approximately between the second and fourth intercostal spaces, with the probe positioned in the body's parasagittal plane and the probe indicator pointing toward the patient's head. Interpretation: the views were first interpreted individually and then summated into an overall impression. Let's begin with the individual views. Here's a representative ultrasound clip of the patient's right anterior chest. Question 1. What best describes the sonographic findings? Select all that apply. A. Sonographically normal lung. B. Focal absence of lung sliding. C. Pathologic B lines. D. Consolidation and/or effusion. The best answer is A. Sonographically normal lung. In anterior lung zones, sonographically normal lung has two main features. First, just deep to the ribs, one should see an active pleural line with lung sliding. Second, deep to the pleural line, one should see A-lines, which are horizontal reflections of the true pleural line. For more on A-lines, please see the March 2025 POCUS Case of the Month, Intro to Lung Ultrasound. Here's a representative ultrasound clip of the patient's left anterior chest. Question 2. What best describes the sonographic findings? Select all that apply. A. Sonographically normal lung. B. Focal absence of lung sliding. C. Pathologic B lines. D. Consolidation and/or effusion. The best answers are B and D. Notably, although we do not see lung sliding, the cause of that cannot be a pneumothorax in this case. This is because a pneumothorax would prevent visualization of structures deep to the parietal pleura. But here, we are able to see well past the parietal and even visceral pleura and into the lung tissue itself. The lung tissue does not appear normal, but instead has a sonographic appearance of a solid organ. The appearance of the lung tissue like a solid organ has been termed sonographic hepatization or sonographic lung consolidation. For ease of communication, we will stick with consolidation for short. Lung consolidations on ultrasound have a differential diagnosis that includes atelectasis or infiltrative processes like pneumonia. Now that we have interpreted the lung ultrasound clips individually, let us summate the data to generate an overall impression. Within the anterior lung views, the right chest was sonographically normal, whereas the left chest was most notable for a lung consolidation. And the posterolateral lung views were not performed in this case due to the presence of surgical drapes. Question 3. Putting together the available ultrasound data, what best describes the overall sonographic impression? Select all that apply. A. Image quality not adequate to screen for pathology. B. Diffuse lung sliding and diffuse A lines, aka sonographically normal lung. C. Focal absence of lung sliding. D. Focal B lines. E. Diffuse B lines. F. Consolidation/effusion. Although the image quality is not perfect, the images were good enough to permit the anesthesiology team to identify the presence of both choice C and choice F. First, let us discuss choice C, absent lung sliding. Although lung sliding was absent in the left anterior views, it is important to emphasize that, in this case, the absent lung sliding was due to something other than pneumothorax. Whereas pneumothorax prevents visualization of anything deeper than the parietal pleura, here in the left-sided lung views, we were actually able to see something deep to the visceral pleura. Choice F, a consolidation within the lung. In the presence of lung consolidation, it is common for lung sliding to be subtle or absent. This is because lung sliding disappears with loss of regional ventilation, and regional ventilation is abolished by the two main conditions associated with sonographic lung consolidation, atelectasis and pneumonia. Now that we have narrowed the differential diagnosis primarily to lung consolidation, let's now discuss how the anesthesia and ICU teams were able to integrate the ultrasound data into their medical decision-making. With the help of the lung ultrasound data, the anesthesia team was able to narrow the differential diagnosis to lung consolidation and its causes. Since one major cause of lung consolidation is pneumonia and/or mucus plugging, the anesthesia team then elected to perform bronchoscopy. The bronchoscopy revealed some scattered secretions in bilateral proximal airways that were suctioned out. Subsequently, the patient's oxygenation improved enough to permit the surgery to continue. At the end of the operation, the patient was brought to the surgical ICU, intubated, sedated, and mechanically ventilated. Next, repeat chest X-ray and lung ultrasound were performed. Now the findings from these two modalities were finally concordant. Chest X-ray now showed a clear opacification of the left lung. An ultrasound of the left anterior chest revealed persistence and expansion of the lung consolidation. Based on these dual imaging findings, bronchoscopy was repeated by the ICU team with the removal of thick left-sided mucus plugs, which were sent for culture. While awaiting the culture data, the patient was started on empiric broad-spectrum antibiotics. After therapeutic bronchoscopy and initiation of antibiotics, the patient's hypoxemia rapidly improved and he was extubated successfully on post-op day 1. The subsequent sputum culture grew out Klebsiella, confirming the diagnosis of pneumonia, even though the patient had arrived to the hospital as an outpatient and reported no active respiratory symptoms pre-op. This case highlights an important concept. Lung ultrasound and portable chest X-ray each have distinctly different diagnostic accuracy for detection of several important intrathoracic conditions. When it comes to pneumonia, a portable chest X-ray has slightly higher specificity, 98% versus 95% for ultrasound, but ultrasound has higher sensitivity, 95% versus 87% for chest X-ray. Stated another way, a portable chest X-ray will miss something like 13% of pneumonias, and the majority of these missed pneumonias are detectable with lung ultrasound. For detection of pneumothorax, portable chest X-ray and ultrasound each have high specificity around 99 to 100%, but ultrasound has significantly higher sensitivity and is able to pick up pneumothoraces that are invisible on chest X-ray. And for detection of pleural effusions, lung ultrasound outperforms portable chest X-ray in both sensitivity and specificity. So here are the take-home points. Lung ultrasound and portable chest X-ray each provide only a partial glimpse into the thorax. Both of these modalities are imperfect and capable of generating false positives and false negatives. When the two modalities disagree, clinicians tend to reflexively toss the ultrasound data into the trash. But one person's trash is another person's treasure. Ultrasound can reveal certain pathologies that are hiding in plain film sight. This concludes the Open Anesthesia April POCUS Case of the Month. For more of this series, stay tuned for the next Open Anesthesia Lung POCUS Case of the Month coming in May 2025.